Hello there, we are back. Today is the day that we are going to show to you how to link the diagnosis treatment planning with the biomechanics. This is the day that I'm going to send to you some information from here to all over the world so you can understand better how to treat your patients faster with a better refinement, because everything is based on what you already know. Everything is based on the diagnosis, treatment planning, and the biomechanics. That's why in this class today, class 2, we are going to link these three pieces together so we can have a better treatment. Thanks for being with me. It's very important for you being here with you again. The second day of our 3-day webinar series, and you being here means a lot to me. Yesterday we had almost 10,000 orthodontists from all over the world gathered with us, together with us in this class. And today I hope we have something similar to what we had yesterday. Hope you enjoy our class today, and hope you enjoyed our class yesterday. Today we're going to the second step. We're going to focus on the 3 pillars of orthodontic treatment, meaning I'm going to understand the problem, I'm going to give to the problem a solution, the treatment planning, and I will establish the best biomechanics for that solution to be very fast. Fast, I mean, when I say fast, don't misunderstand it. I don't mean that you're going to hurry things up just to finish your treatment. I mean that you're going to understand that biomechanics is all about anticipation. You see the problem coming and you anticipate it. I will have the solution for the problems that I'm generating during my treatments. That's it. Pure and simple. I'm not proposing magic solutions here. I'm proposing the right solution. So we are going to do this now. So this is the day that we're going to focus on that. What are the problems? This class is not going to last 2 hours. This is a shorter class, but direct to the point. I'm not going to say what I said yesterday about my own life, about my own path in this journey. I'm going to show to you how to do. I'm going to show to you how to tackle orthodontic, very difficult treatments using this simple way, simple method. And also I'd like to advise you that the best experience for this type of class is in the desktop. So if you have a desktop, go there. We'll have questions and answers at the end of our presentation. If you are watching the recording, stop now and look for the class. Okay, so this is the class that we are going to give to you now. We'll get into the content in a few seconds, but first, I'm always putting this here, guys, because I need to remember everything. I'm not that young anymore, and that there are some times that I lose things. Until the end of this class, before the Q&A, I'll give you a gift. Actually, I'm giving you a gift for you to savor this gift for tomorrow, okay? I'm going to give you something for you to think about for tomorrow. The 3 pillars for faster and more efficient treatments is what we're going to focus now. So, this is where we start. There are factors that delay and sometimes compromise the successful outcome of orthodontic treatment. Those 3 situations are very common in my clinic, in your way of treating, and since the 90s, when I started working in orthodontics, the end of the 90s in the last century, I had this problem. I told you about that yesterday. But the problems that I had, they are generated by these 3, mainly because of these 3 topics here. Careless diagnosis, absence of consistent planning, and incorrect mechanics. And if we can escape those 3 traps, we can do things faster, we can do things with more precision. And this is what I'm planning today, showing to you how I do that based on these 3 pillars: biomechanics, treatment planning, and also diagnosis. I'm sorry, I think something got wrong here. The names didn't appear, but this is something that happens in live. Okay, and again, my team here telling me that please, when you have the opportunity, take a screenshot wherever you are, in your iPhone, in your laptop, wherever you are, take a screenshot and tag me. I will repost with you, okay? And I'll be thankful for that. And this is the three pillars: diagnosis, treatment planning, and biomechanics. I need to fix this the next class. No problem. So the first case I want to show to you now, the first case that for me, it will show to you the importance of understanding everything in orthodontics is this one. This is apparently a simple case, but it's really not. I'm going to show to you why. This patient came to me with the chief complaint of trying to have a better smile. She had been treated before. She was an orthodontic treatment before, and she wanted to change her smile because she didn't want to have that very crooked anterior teeth and narrow maxilla. She understood their problems, and she wanted to change that. And she went to other orthodontists, and they told her, this is a surgical case because you have this problem and that problem. And in my point of view, this case is not surgical because of some aspects that I'm going to show to you. Coming from the diagnosis, always diagnosis. Treatment planning went forward because of the diagnosis. I saw the problems, and I established the solution from that problems. And I'm going to show to you that the third pillar is very important also. Biomechanically speaking, if you see things and anticipate the problems based on the correct biomechanics, because we know that in orthodontics there's no free meal. You do something, you pay for that. You do something, you must pay based on what you're generating. Let me tell you something. I have a student of mine that is following me frequently in face-to-face courses, in online courses, and she told me something. I will quote her. This is Rose. Rose is a gentle woman, very polite woman, and she told me in the course that she went, I think it was, I don't believe, I think maybe in Iraq, and she told me, Prof, do you know what I do all your courses and why I come to you in face-to-face courses also? What do you tell me, Rose? Why? Because you have this course before. And she told me, because I think that I don't know enough yet. And not knowing, my feeling is that I'm creating my own malocclusions for not knowing what to do. This is very powerful. This is biomechanics. If you don't understand the problem and you don't link the solution to this problem properly, you're going to generate another problem. And not knowing that you're generating another problem, suddenly you are going to be trapped in a very difficult situation. Sometimes you can't even go out of that situation, can't escape of that trap. That's why you need to anticipate orthodontic side effects in orthodontics. This girl came to me, Giovanna, very beautiful girl, came to me with that chief complaint, and she wanted to change her smile. We run the sequence of the same thing, diagnosis and treatment planning, and what I saw in her face was that. Smile. I have in my course this part of the smile analysis, which is very important for us as orthodontists. Why smile analysis is that important? Because at the end of the day, what you need to deliver is a better smile. We need to deliver something beautiful. And the smile is what patients come to change. They come to change the things that they are showing to the world. They are showing in social media, they are showing in their photographs. So if we don't deliver a better smile, we are really not tackling, we're really not fulfilling patients' needs. And this is bad, because this is something that's not success. And she came to me with this in mind, and I wanted to change her smile. And some aspects of her smile showed me that I could change that using a very fast strategy. I'm going to show to you why I call this fast strategy. Because we are going to attack everything at the same time. We're going to tackle all the problems at the same time based on the diagnosis. Follow me. Going on, we don't have a cant in the occlusal plane, and then part of the smile analysis that if you are part of my courses. You see that I have this step-by-step of analyzing the smile, analyzing the buccal corridors, the proportions, the micro and the micro analysis. We do that because we must consider everything up front, even before putting a bracketing position, even before thinking about starting the treatment. We must understand the problems that we can change, and we can change several things in orthodontics. Also, we can change this, the proportion. We have here what we call a square shape of the central incisors. And the central incisors, they are the leading actors of our play. They need to be beautiful. We don't have beautiful and showing central incisors. So this is something that we can change. But how can we change that? Because when we change this, we can change elongating the crown from this point to the tip, or elongating the crown by means of surgery. I can remove gingiva to elongate the crown. I will have a bigger crown, a higher crown that will resemble more mature smile, beautiful smile. And we need to understand what are the problems so we can choose the best solution for that. And the best solution for that, you see here 100% of overbite. Of course, you know that the best solution for this is not elongating in the tip with just for crowns. We can use that, but we can do something different. Let me go on so you can understand that with me. So I want to do that. I want to elongate the crown and have a good proportion. We don't have a good proportion in anterior segment. Lateral incisors, they are not proportional in size in relation to the central. They are short, and we can do that. We can change that. And here is the point. Here's the main point, guys. I have this face, and I look at her face. She's a young girl. She's like 27. I don't remember exactly, something like that. And she's not showing 27 for me. She's showing more age. Her face is not a young face. Why do you think it's happening? Because the volume of the lower third is very important for us to see a face as a young face. It needs volume. Because we know that with time, we are going to see something like that. Look at this. And here we have this beautiful girl that I created in Midjourney. I love Midjourney, as you can see. And the volume of the face, when we shorten the volume of the face with time, we accept that people with time they are going to show less volume in the lower third. And this is common. So if we see someone young with that type of short volume of the face, we think about them as older. And we can change that. There are indications for that. We can't do that, for example, if we have a class 2 with a short mandible. We can have a class 2, but not with a very short mandible, because we know that a class 2 can be because of the mandible, because of the maxilla, a composition between both, or can be also because of the lower anterior face height increased. We have several ways, and we must focus on the specific case that we can treat. I'm going to show to you in Giovanna's case why we can treat in her case like this. We see here that this young lady going older, she's diminishing, she's decreasing her lower anterior face height volume, which is going to eventually happen to everyone. We can change that, yes we can, but I think we need to respect also the age. And we need to ask our patient, do you want to change that? Because I don't start at a point that I'm treating everyone like a serious treatment. No, I do what I need to do based on chief compliance, based on what I can do for having a better smile, a better occlusion, but I need to ask my patients, do you want to do that? Do you want really to do that? Because I can't do, but we can't force our patient to have what we want. Going on here, I'm going back to her case. I see that she has this lower anterior face height decreased. Also, she has this type of occlusion. uprighting upper incisors. We can change that, and this is going to benefit her lip volume, okay? Lip volume, and then we come to the torque. We had another course about torque, which I love, because torque changes everything in orthodontics. When we manage the torque correctly, we can do things very fast. And here it is, going on. Giovanna has this counterclockwise rotation of her mandible, and some angles also that we can change. And we have here the projection of upper lip. I use here the Portuguese version. I'm gonna change that. Okay, I'm gonna tell you everything here. Good maxilla, upper teeth are uprighted, are retroclined. We are going to change this. And here we have her relationship in cephalometric analysis. So we see that for this maxilla, I have a good mandible, but I have a lower anterior face height decreased. So this is the facial type in which I can do this type of treatment. I mean, I can do this increasing the lower anterior face height without jeopardizing her smile and her profile. Why is that? Because she has a good mandible, but the mandible that I see here is hidden behind the maxilla. I want to show more mandible. I want to show more volume in the lower third. If I had a short mandible in this case, I wouldn't treat her like this. But let's move on so you can understand better. We have retroclined upper incisors, and here we have her occlusion, class 2 div 2, I'm sorry, class 2 1/3 in the right side. The molar is almost full step class 2. In the left side we have premolars 1/3 of class 2 and molars almost class 1. And here we have the treatment that I'm proposing in her case. The treatments for those patients are almost the same. I mean, lower anterior face height, and this is the way we must understand orthodontics. Lower anterior face height can be treated in class 2 patients or class 3 patients vertically. I can change things with the vertical in mind. How is that? For example, this case here that I showed before, I think maybe you have seen this case before. This is Pedro, and he came to me because his mother is a professor of orofacial harmonization, which is a big trend here in Brazil. And I was giving a course in her classes and of smile analysis and cephalometric and facial analysis. And she saw some cases in my class, and she told me, Kleber, I think my son has the same problem that you're showing. Short lower anterior face height. Short lower anterior face height. I see cases that you treated, that case that you showed here now, today, that you increased the lower anterior face height, and it gave to the patient a youthness aspect. I think Pedro needs that. I think I'm gonna give you my son to be treated. And I told her, I want him in my office. Let me see the problem. And I'm gonna show to you, based on Pedro's treatment, what I do in those cases. Same protocol, lower anterior face height decreased, good mandible, good maxilla, and we have this counterclockwise rotation of the mandible. This is what I'm doing in patients like this. Not all cases are the same, of course. They have some similarities, but they have differences also. We need to adapt. We don't treat everybody with the same pill. We don't treat all illness with the same pill, but we adapt. This is what I do in cases like that. Patients with this overbite, deep overbite, they have this, look for that. They will have the curve of Spee, deep curve of Spee, and we can treat this with any specific treatment. This is the kind of treatment that we must address. This is the type of treatment that we say to our patients. You need to be treated, otherwise with time you're going to worsen your malocclusion. Your malocclusion is going to be much, much worse in 10 years, in 20 years, if we don't do anything. If we don't approach the problem now, the occlusion is going to worsen because of the contact that we have in anterior segment that will give further proclination of upper teeth and will increase the crowding in the lower and maybe in some situations cause severe bone loss. And we want to treat that. How can we do that? So understanding the problem, we go here to his profile, or a profile like Pedro's and like Giovanna's. We have this maxilla, mandible, so we have a compatibility between the maxillary size and mandibular size. Go back to the class we gave yesterday and see the importance that we give to this topic. Maxilla and mandible in size must be compatible, and also the lower anterior face height. If we have some unbalance in the triangle, we tackle the problem. And the problem here is the lower anterior face height, which is decreased. So we can increase it. Let's move on. We have a counterclockwise rotation of the mandible. We have in those patients usually a short upper lip in relation to the lower lip. And the relationship between the upper incisors and the stomium sometimes is not good. So we can do that. We can increase the lower anterior face height, rotating the mandible down and backwards. So when we do that, when we rotate the mandible down and backwards, what we have? We have a lower anterior face height increased in relation to before. This is what we are doing here. And biomechanically speaking, what do we do for that? This is the tip that I'm going to give to you now. The tip is, how can we do that faster? How can we increase the efficiency of the treatment by decreasing the treatment length, the treatment time? We can do that treating the vertical. How can we treat the vertical? Let's move on so you can see. Now we have a better relationship between upper and lower lips. Good relationship between stomium and the upper tip of incisor, the upper tip of the upper incisors. So this is what we know that we are going to have. And now the biomechanics, the third pillar of the success in orthodontics. Now the biomechanics. And this is the tip that I'm giving you now. For those cases when we can do this type of treatment, I'm going to show to you one way of treating this. Of course, I can't show to you all the ways to treat that. But I'm going to show to you a very... We're going to level the curve. We're going to flatten the curve of SPI by means of increasing the bite, posterior bite. And this is what I do. I will place in the upper first molar, I will place a bite ramp, a bite plate, so we can have now this contact here. Pay attention that the second molar is there, not touched. I will leave the second molar alone. I don't want to rapidly extrude it, because this area here, it has a very soft bone, and if you have a strong contact there, you may cause bone loss. So I want the second molar to go naturally, passively down. And now I have this, and this is the second tip for you. I don't use the reverse curve, because the reverse curve is it takes long to correct the curve of SPI. Why is that? Because this is biomechanics, guys. Because when I do that, when I come to this point here, I'll see that the force that's going to be applied in the down direction, this direction, is a very, very low force. If there is a force, because it will be canceled along the brackets. So I prefer to do this way. I use a cantilever for that in this case, guys, I will use a cantilever with a straight wire. And what I do here is I will measure the force, and the force that I'm applying here is nothing more than 60 to 80 grams. When I do that, I will generate here a moment in the molar based on the equilibrium forces, based on biomechanically, I will have a good moment here. Let's summarize the problem. I will have a good moment here. The moment here will upright the molar, which is inclined, it's angulated down mesially. This is what is going to happen in this class 2 cases with a deep curve of SPI. So when I do that, I'll have the moment in the molar that will tend to intrude the second molar and to extrude the premolar, everything that I want, and also intrude anterior segment. When we do that, we are going to give efficiency to the treatment. This is going to happen in 2 to 3 months. Try to do that with aligners. Try to do that with simple mechanics like curve of SPI. So this is the control that you're not having. The magnitude of the force that we are really applying in the anterior segment, you can't say what is this magnitude. Of course, with time, it's going to work, but with a lot of time. Not quick, not fast like this. I want efficiency in my treatments. That's why I use this protocol. Tomorrow, I'm going to give you an article that's going to show to you how to tackle this, how to do that. Okay? Here we have it. So look at this. Pay attention to the arrows here. We have the arrow in the distal to the molar going down, medial to the molar going up, and we have also in the anterior segment the vertical component here in this point, mesial to canine, and look, second molar is free for erupting, and we will have this type of movement. Don't forget, when we do that, we are increasing the arch length. Can you do that? Is it something that you want to do? Increase the arch length, so this is the mechanics that you want. You can't do that. You can't do this type of movement without increasing the arch length. Not possible. Why not? Because this is something physical. We have a curve, and when we straight the curve, when we when we do this straightening the curve, we are going to have a longer perimeter. So in this case, when we do that, it's not possible to correct the curve without increasing the arch length. So pay attention to this topic, because sometimes you can't do that. And if you can't do that, you must apply other strategies. For example, the IPR. You must need to do the IPR. I really don't like to do much IPR, big IPRs, but sometimes we need to go with IPR to avoiding this type of inclination of anterior teeth. So in this case, you are going to have this outcome. You are going to increase the inclination of anterior teeth and the arch length, like this. And if you can do that, okay. In Pedro's case, I wanted to do that because I wanted to give to him more proclination of lips, more volume of lips, with torque in anterior segment, upper segment, and torque or inclination in lower. This is part of my strategy. Here we have before, we see the curve, straightening the curve, look, just 3 months to completely straighten the curve. I go on with my sequence of arch wire, but I will start in day 1. Day 1, I will do the bonding of the arch, the lower arch, from second molar to second molar, and I'm giving the day 1 also, I'm giving the cantilever to the system, okay? Here we have it. And okay, now I'm gonna wait for the extrusion of the second molar. When I have it, I will establish the scissor in anterior segment, opening anterior segment. And now I want to extrude also premolars and anterior, the teeth that are anterior to the first molar. How can I do that? I will cut the wire, the mesial of the molar, and I will start using elastics for extruding anterior teeth. The elastics here, they have the vector of the problems. If it is a class 2, give a vector in class 2. You see now I will have the extrusion of anterior segment, and after establishing contact between premolars in the upper and lower arch, I will release the second molar, the first molar, I'm sorry. And then I will have this. Tip for you, every time you do the correction of using elastics, think about establishing having stability, I mean. How can we have stability in such cases? It's not just about extruding. If you do that and just release the elastic, you're going to have a very fast relapse. So you must secure the position. How can we do that? We keep the elastics for another 3 months. Why is that? Because within 3 months, we have 2 renewals of the periodontal ligament fibers, and we have bone growth surrounding the roots of those teeth that we erupted, so we have more stability. This is a tip that I've been using for a long time now. And now I have the possibility of grinding the bite ramp. And now I will, again, extrude molar. So this is my protocol in 100% of the cases that I have in which I have this situation. I can increase the lower anterior face height. But again, remember, one of the problems that we have in our treatments is not understanding the case. It's not applicable in all cases. You can't do that in a patient that is a short mandible patient with a class 2 and lower anterior face height. Because if you do that in a short mandible patient, the rotation of the mandible will increase the convexity of the face. So what can we do in such cases? Surgery. Pure and simple. Surgery, just that. Otherwise, you're going to decrease the face beauty. And I don't want to do that. Here we have it. So again, 3 months. Remember that. 3 months, another 3 months, the elastic in position for securing stability, okay? And here we have it. After that, we can remove the appliance. So guys, what to do in the cases like this, in Pedro's case, you see a better position of the upper and lower lip because of the torque, because of the inclination of both. So that was planned before. And we have also a good relationship between upper and lower lip, almost perfect. Before that, we had a short upper lip. And we managed to change that because of the diagnosis, the treatment planning, and the correct biomechanics. Coming back now to here we have it, the comparison. Coming back now to the Giovanna's case, what we see is this. What I want to do now is day one. You see here, we boned the lower arch, and after bonding the lower arch, same day, we applied mesial to the canine, one cantilever in each side. 60 to 80 grams per grams here. And the TMA, I love the TMA. I always use TMA for that. And 1 month later, what we have? Straightening the curve, flattening the curve. 2 months, look at that. Curve is almost flattened, almost flattened. And then we are going to the second part of the situation. And here we have the biomechanics playing its important role in the process. If we understand the biomechanics behind that, and we can do, remember what I said before, we are going to attack all the fronts at the same time. I want to do correct the torque in the anterior segment because I can't go further. In this situation, I have a class 2, pay attention to this topic here. I have a class 2 in canines, and the canines in class 2, they must go distal, but I don't have space to retract. I don't have clearance here to retract anterior teeth. So what will I do? Will I stop mechanics here and then correct the torque so we can go on with the retraction? No, 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 we can do everything at the same time. Biomechanics, how can you do this? I promise you that you're going to fasten your cases up to 100%, twice the time faster. I promised you that you can cut your treatment by half. How can you do that? This way, you don't need to wait until you have the correction of the torque so you can go on with the retraction. You can do both. How can we do that? Look at this. This is what we call the two-couple system. I'm going to give to this case a torquing arch. The torquing arch is this. Look at that. And I'm going to ask you something now so you can understand how important is to master the tripod, master the biomechanics also. I'm going to ask you now about this. Deep overbite, I want to intrude anterior teeth. Let's say we want to intrude upper anterior teeth, and I want to do that by means of a torquing arch. I have a negative inclination of upper incisors, and I want to do this. I will segment the problem. I will correct the anterior segment using anterior teeth, central and lateral, 4 teeth, and I'll have the molar aiding me, helping me to do that. So I have this segment, 2 segments. I propose that we use a 2-couple system for this. Look at this 2-couple system, beautiful. I'm asking you now, this is what you see when we insert in the posterior segment, I use TMA for this, but you can use stainless steel. I'm using a TMA 17 or 1925. And when I do the activation in posterior segment, I see that anterior segment is like this. The upper incisors, they seem to be what in this case? The question is, what is the expected movement in the incisors when this 1725 TMA wire is inserted into the brackets of the anterior teeth? So most of you, I'm sure about it, are going to say that they are going to intrude. But we can't say that because this is a 2-couple system. If you applied 1-couple system here and just tie this to anterior segment of the wire, yes, they will intrude, for sure, for sure. But in this case here, since you are inserting the rectangular wire inside the slots of anterior teeth, you can't say that unless you measure the torque that you have in anterior teeth. Meaning, you measure the magnitude of inclination of posterior and anterior when you insert. Look at that. The options would be, when you do this, anterior teeth intrusion, most of you are going to say that, posterior teeth extrusion. Or option B, anterior teeth extrusion, posterior teeth intrusion. Of course not. You're not saying that. And the third option would be no vertical movement will take place either in the anterior and posterior segment. So what can you say about it? What I'm doing here, guys, is giving a torque in anterior segment, and I'm going on with the retraction of the canine with the main arch, in the main arch, using a class 2 elastic. And in her case, a class 2 elastic may help. May help, why? Because I want extrusion. If I didn't want extrusion, I wouldn't use this class 2 elastics. Why not? Because it will extrude the molar. And I don't want that to happen in some cases. In this one, I intend this to happen. Understand that? Based on the diagnosis, her facial features, I'm saying that I want that side effect. If I didn't want that side effect, I would avoid using elastics for that. I could have other options. For example, I could use a protractor, a mandibular propulsor. This is another option to avoid an extrusion of the lower molar. But in this case, I want. That's what I want to say. Well, I don't want to stop the movement of posterior segment. That's why I'm doing this. And now I go back to the question. A 2-couple system can be tricky. Why is that? Because you might think that this upper incisor will intrude, but it depends on few things, like this, for example. Let's say I have, in this case, we evaluate the possibilities of the system, one of the possibilities of the system, which is intruding. I will go down with anterior segment. I will go down with the upper arch in anterior segment. And when I measure the force, I will say, let's say we have 100 grams. I know that by 100 grams, I have approximately 30 millimeters of distance between the molar and the anterior segment. So knowing that we have in the system a moment that is approximately 3,000 grams per millimeter, as you can see here. Let me magnify a little bit so you can check it. You see, we have 300 grams per millimeter because the counterpart of the moment of the system is here. So we have in this part a clockwise moment, and if I insert in the anterior segment and I will measure posterior displacement of the wire, and when I measure this, I find here that we have, how much is that? 150 grams of intrusion in posterior segment, in intrusion in posterior segment and extrusion in anterior segment. Well, you see that we don't have a balance between posterior and anterior moments. We have one moment predominant, which is this one here. Why is that? Because the force, because when I inserted here, it was higher than when I inserted the posterior segment. So this moment here in the anterior segment will be the predominant moment. What's going to happen in such situation? Well, I will have, if I do the calculation here, I will have force in anterior segment, 50 grams in anterior segment for extrusion, not intrusion, because of the unbalanced system that I created here. And I have more moment here than the posterior segment. So what we are going to have is this situation. We are not really intruding anterior. We are correcting the torque, yes, but we are actually extruding anterior. And if we cinch back, the problem is going to be great. It's going to be big because the anterior moment will dictate the movement here in anterior segment being greater than posterior. So it will pull the arch towards anterior segment like this. So if we cinch back, we will lose anchorage. You see the problem now? That's why we must understand everything that we are applying. That's why I don't believe when you go to the internet, to the Instagram, wherever you go, and you see before and after. I told you before, this is not fair with you. This is not fair with my students. That's why I try to show the problem and the solution, and why that solution is a good solution. And if someone tells me, no, prof, you're not right, this is wrong, I will listen. But I'm based on solid knowledge that I acquired along those years. That's why I'm trying to give to you this, because this is part of your career. Solving problems faster without the need of going and coming back, going forth and coming back. You must understand everything and give this step by step. Diagnosis, treatment planning, and biomechanics. In this case here, I want to do this. I want to avoid vertical components. That's why I will apply the geometry number 6. And the geometry number 6 will help me vertically cancel the problem in vertical displacements. And here we have, I'm measuring the force, the vertical force in both sides, measuring the vertical force in both sides, and when I measure the force, I'll see that I have a symmetric force. We can do this by seeing the shape, or we can do that by measuring the force. I prefer to measure the force because I cancel the variables that I can insert in the system. Vertical forces are now canceled, and we have something like that. Look at this in detail here. We have the same force, the same magnitude of vertical force, meaning now I'm canceling the vertical forces in each side of the system. Doing that, I'm giving to the system just moments like this. And now I will not cinch back because I don't want that to happen. What I want here actually is a free movement of the crown of posterior teeth going distal. I will profit from this. I will benefit from this. I will have more distalization in the molar, and I'm wanting to have this. I want to have this. What I have now is, in this case, look at that, guys. What am I applying here? The two-couple system to correct the torque in the anterior segment, and at the same time, I'm applying this moment to the molar, and I will connect this segment to premolars, and I will also give a distal force here. Everything is helping me to correct the class 2 in this side. And this is going to be fast because of that. Because I'm using the biomechanics in my favor. I'm using the biomechanics to fastly correct that. You see this movement? Very fast. Treatment time, length, 10 months. To correct that class 2. To correct that problem. And now I'm giving to this a very slow extrusion of the molar. I told her I prefer to do this way. I'm grinding and grinding so I can have more stability. That's it, guys. I want to do that in almost all cases like this. I want to do that because I can correct segments of the problem. You see, let me rewind here. I knew that I wanted to increase the lower anterior face height. I knew that by doing the posterior bite ramps, I will rotate the mandible down and backwards, and I will give space to correct the class 2. I'm correcting the class 2 now using what? Using the biomechanics. So everything that I set for this case helped me to treat this case faster. If you go like in a protocol, some standardized protocol for every patient, aligning, leveling, giving the curve, reverse curve for correcting, for flattening the lower arch, and then after correcting the torque, going on with the retraction, it would take 2 to 4 years. From 2 to 4 years. I'm not saying because I think, I'm saying because I'm sure of that. And when she came to me, she told me that all other orthodontists told her that her case would take at least 2 years to 3 years. Because this is common sense. I know the problem is a big problem to be correct here. But if I can understand and I can give to her the solutions like this, I will treat her faster. That's it. So I'm having the pre and post. Also, I wanted to increase the buccal inclination of posterior teeth because she had a negative inclination of posterior teeth. And when we see the smile, that large buccal corridors, it give us that sensation of aging of the smile. And again, we are correcting that for benefiting from that type of movement, giving to the patient a beautiful buccal corridor, more filled buccal corridor. Of course, there is a limit for that. You can't do that just giving more and more expansion. There are indications for skeletal expansion and dental expansion, and one of the indications for dental expansion is the inclination of posterior teeth, negative, extreme inclination, negative inclination of posterior teeth. Now we see before and after. Now we see her face before and after. So what do I have here? I have better lips, I have better relationship, and also her smile being changed. Look at that, month by month. Now intruding anterior because I wanted to grow, to elongate her teeth. Now because of the intrusion, because of the torque, I want to elongate the teeth downwards, this way. And now providing enough room for that. And this is Giovanna after finishing treatment, after debonding and after their veneers. So everything was planned before. In advance, I knew that she would should have this elongation by means of surgery, periodontal surgery, plus veneers. Why didn't I do that before? Because she already had 100% of her overbite. How can you do that in that situation? How can you elongate posterior teeth with negative inclination? Not possible. So I'm preparing her to have the smile that she wanted in 10 months. Everything based on the tripod, diagnosis, treatment planning, and biomechanics. Pure and simple. Believe me, it's not complicated at all. Just using the knowledge that we already have. Here we have Giovanna. Look at her face before and after. 10 months after initiating the treatment, you see she has a fuller profile, a better profile. And now we see her lips. Look at her lips, just because of the torque, before and after. And we see the position of upper and lower lips compare before and after, and we do the line of evaluation, we see that her lower lip went forward. And posterior teeth, filling the buccal corridor with a good inclination of posterior teeth. And we have the smile, the micro-analysis of smile. What we have here is before, square shape, after, we have a long, elongated crown. Why? Because we had a good treatment planning without increasing the overbite. And this is because the treatment planning, and this is because of the biomechanics. Okay? So I want to say to you that something, because we established this name for this type of webinars, Future of Orthodontics. The future of orthodontics is here, it's now. But the future of orthodontics merges past wisdom with evolving knowledge, respecting sedimented scientific knowledge while embracing cutting-edge technology. We must put everything together now, guys, so we can have the best of orthodontics. We can't forget what we had before. This is not fair. This is not true. Believe me, when people tell you that the best way to do things is by using a computer game of just changing the position of teeth, this is not true. In your daily practice, it's not going to happen that way. All those clean checks, all those, I love aligners again, but all those cases that we see in the clean check that they give to us, they're not true. They're not true. There's something that is close to that, but they're not true. In orthodontics, technology must be act in our favor, must be there for us. This is good technology. This is something that we use for, in this case here, for understanding part of the planning here, understanding where I'm doing, what I'm doing for the case, and positioning my tool for giving to that case a good treatment. This example here is very interesting. I wanted to do mesialization of upper teeth. So for mesialization of upper teeth, what I wanted is to insert this mini implant in this position, close to the first molar, because the first molar is going forward, and the second molar will eventually reach that position. And now what we do, we use technology in our favor. CBCT will help me to position the mini implant, to right position the mini implant, extraovular mini implant in this case, and it's not easy. I see many people using like their own beliefs to insert the mini implants, just eyes and touch. I don't think this is precise enough. I really don't think. So I'm using, in 100% of my cases, extraovular mini implants, I'm using this. Guide, surgical guide, CBCT plus surgical guide. Unfortunately, I don't have enough time to show to you how I do, but I'm really in love with this type of planning. This type of planning gives me freedom and gives me an easy mind, a free heart, because sometimes I don't even know when I'm positioning the mini implant. This way I know, this way I can do. And I'm using that for giving the treatment that I need. In this case, what I want to go forward with this teeth, anterior teeth. I have this 4 millimeters, which is within my treatment planning. I don't know how to say, but I'll say that giving 4 millimeters here give me freedom to correct, let's say, to correct the malocclusion. That's pure and simple. Correct the malocclusion by mesialization of posterior segment. So this is why I put this mini implant close to the apex of the molar. You may be thinking now, why didn't you put away of this? Because there was no bone. There was no bone for that. Sometimes we think that we have bone, but we don't. This is why I use this type of technology to understand where I can put the really and safely position the mini implant. Here it is, and now I'm using this loop for pushing forward anterior upper segment. And here we have the case. I don't even want to show this case for, but just for you to understand how fast it is. We have the case here, class 3, anterior segment edge to edge. I did the extraction of 1 molar, and after extracting that molar, I did that mini implant, extraovular mini implant, and I'm doing the mechanics with loops. So loops are very good. I love loops. I know that. I love loops because they will give me a faster treatment, a more precise treatment, without the need of spending that much time for correcting this. No friction. Correction based on the control, the tridimensional control of the problem. So we have everything in our hands. Closing the space, losing anchorage in lower, losing anchorage. So you see that we have now almost finished, and we have now that possibility of correcting. Another example of the future of orthodontics in our hands. This is another case treated this way. I'll show to you 2 tools that we have nowadays that can fasten up treatment. You already know one, the TEDS. The second one is the three-dimensional way of seeing the planning. This patient is a surgical case here. This patient, she was going to have the impaction of maxilla, and because of that, I would need to understand how the surgery would take place. Was it a surgery with impaction of posterior and anterior at the same proportion, or will I have a differential impaction? Or this is what the treatment plan for her. In her case, because of the dolphin analysis, this is another tool that we use a lot, we have now the possibility of knowing beforehand what's going to happen to anterior teeth. So sometimes you have like this extremely proclined anterior teeth, and people say, for preparing cases for orthodontic surgery is easy. I just need to align and level. It's not true. You need to plan everything for that. It's not true. In this case, what I have is the intrusion, impaction of anterior segment, and this impaction, differential impaction of anterior segment, would bring more inclination to anterior teeth. Like that. Let me show to you again. These numbers we're not going to use now. But what we have here is already proclined anterior teeth, upper and lower. And what's the problem for me? When I do the impaction of anterior teeth more than posterior, I will increase the torque of anterior teeth, which is already excessive. I don't want that to happen. So because of the planning, because of the possibility of using this before treating the patient, I planned the extraction of 4 premolars. And now I'll do the extraction, everything's ready, extracting the 4 premolars and using TEDS. This image here says a lot. Look, diagnosis, treatment planning, biomechanics, using the ancient concepts, pure biomechanics here, with the technology embedded in such cases. Everything will be faster this way. So orthodontics is like this in my mind. Whatever I can do to have a better treatment, a faster treatment, I will use. I'm using here the loops, I'm using here the TEDS, I'm using here all the technology available to understand that posterior segment will be more impacted than anterior segment, and I will plan for that using that strategy. Now I'm using the old concepts, not old, they are extremely new because they are the best options for us. They are the best option for us. We have the V-shape again. This is how we do the activation of this type of loop to avoiding the vertical components and to benefit from the moment created by the anterior segment. No friction here. We give to the system more efficiency. And we wait until we have the correction of the torque in the anterior segment. And again, we do the activation. This is how we do that and how we fasten up mechanics. This is what we're going to have in such cases. Here it is. And we can use also old-fashioned device like this. So after removing the mini implant, I wanted to lose anchorage. And for losing anchorage, I would have the option to use another mini implant, but she didn't want. Maria Clara told me, Prof, she was my student, and told me, Prof, I don't want to have another mini implant. Do I have another option? Yes, you have another option, Clarinha. The option is using this mask, face mask. Do you want to use that? Are you going to really wear the mask? Yes, of course. And she's a very good patient. She really wore the mask. And we lost anchorage that we wanted to by means of that. And here we have before and after. And here we have before and after correction. Place the mini implant in the right position. Plan for the finishing of the treatment. Are you going to do the plastic surgery, periodontal plastic surgery? Everything is planned beforehand. We don't come now and say, now I think I'm gonna do this or that. No, this is not the right way. The right way is to understand the problem, approach the problem with the right biomechanics, and finishing that. I'm gonna show to you tomorrow. Don't miss it. I'm gonna show to you tomorrow and finish it with the best strategy for finishing. Tomorrow, we are going to put everything together. Don't miss it. And here is Clara after treatment, before and after. Look, biomechanically speaking, I want you to see that in, yes, look at this. I'm gonna run the video so you can see here. This is time-lapse video with typodonts. So if I know what I want, if I want to increase the lower anterior face height and retract anterior upper teeth and protract anterior lower teeth or the whole or the entire arch, I can use strategies for that with the correct biomechanics. That's where the biomechanics, we go inside the problem. We go inside this whole picture, okay? Another case, similar to the previous one. Same thing, fast treatments because of good biomechanics and because of good treatment planning. No other strategy will help you that much. Pay attention to this. Another case, I'm going faster now because I know you may be a little bit tired now. Yes, yes, sure. Not that tired, maybe, huh? Yes, yes, I know the timing. So let's move on. Look at this case here. Patient now is wanted to change her smile, and she was treated before. Let me go to the topic that I want to show to you. Look at her smile. Upper midline shift towards her left, lower midline shift towards her right. And this is what I saw in her case. And for this type of treatment, I didn't want to do extraction in her case because of her face, and she had underwent before the extraction of premolar, okay? One premolar. And now I have this. I want to change that. Biomechanics is going to enter now. Let me show you an example of a good biomechanics here. The problem, a little bit of deficiency in maxillary volume. Good nasolabial angle. I want to extrude anterior upper teeth. And I know that I can use a little bit of increasing the lower anterior face height also. Good mentolabial angle. I love this. I love this. And I can do the extrusion. What was the planning for that? Look at this. Extraovular mini implants and the retraction in one side, protraction in the other side in the upper arch, and retraction in the lower side in the lower arch, lower left segment. Everything based on the diagnosis. As you can see, everything based on the treatment planning. Now we come to the right biomechanics for that. What the biomechanics that I'm going to use here? I will use the extraovular mini implants as anchorage plus the loops for helping me to go faster. And we do the extraction of the third molars when we initiate the retraction, because this is going to help us to be faster. Why? Another thing that's based on knowledge. We have what we call the rapid acceleratory phenomenon, the RAP. In this case, the rapid acceleratory phenomenon will help me to treat faster because I'm doing the extraction the day I initiate the retraction of upper teeth. When I do that, I will fasten up mechanics because I have the window of opportunity of distalizing upper teeth very fast without the need of needing to wait a long time for doing that. In her case, look at the mechanics I used. In one side, I used a protraction loop. In the other side, I used a retraction loop. And the midline, upper midline, look at the symmetry of the canines before and after. And the loops help me to give this movement faster. Protruding in one side and retruding in the other side. Based on what? Biomechanics. Before initiating the protraction in the upper right side, upper left side, and retracting in the upper right side, using loops and TEDs. Loops and TEDs. Oh, I love it. I really love it. This is completely different from what we had in the past. Last case to show to you. Again, same strategy. I'm going to just give to you another tip here. Avoid at all costs to use this type of mechanics. The coil springs, they are very bad in many situations. They will give to you something like that. Elastics, they are very bad in several situations also. So base your mechanics on the strategy based on the diagnosis and treatment planning. Look at this. Coil springs, they will help you at some points, but if you keep them long enough, what's going to happen is this. First of all, first side effect, you already know the side effect, rotation. You can avoid the rotation, yes, you can avoid the rotation by using auxiliary mechanics like a palatal control like this. You can do this way, but you have all the other side effects. Like this, for example. The second side effect is widening the arch. Expanding the arch, because the easy way to do this is to open the space is by expanding. And the third side effect, may be the worst side effect here, is that you're going to intrude the anterior segment when you do the coil spring for a long time. Because the line of action of the force you're applying is away from the center of resistance, and all those teeth are going to angulate because of the force of the coil spring. And this is very bad in several cases, especially when we have asymmetric mechanics like this. You may have a kink in the lower arch when you use this for a long time, so avoid using that. Look at my own problems here. Like a long time ago, I had the same problem. Let's see here the problem. We have anterior going forward with posterior segment, and I used a coil spring. Oh, bad mechanics, very bad mechanics. Coil spring open in space, and I was not seeing that, but Mr. Bean saw that. Look, he's telling, what? What are you doing? What I'm doing here? I'm giving to the arch a kink. I'm intruding this segment here because of an angulation of the premolar. So this wire is going down this mesial to the premolar because of the angulation of the premolar, and it's intruding anterior segment in one side. I stop this mechanics and I correct the problem this way. I know that when I apply the line of action of the force below the center of resistance, I'll give a moment that will help me correct this problem that I generated myself. Remember, Rose, I'm creating my own problems here, my own malocclusion here. So I had the opportunity to correct that using another strategy. So guys, this is what we do in biomechanics, in orthodontics, when we understand the problem. We avoid the problem. In this case, stop class 2 elastics. Let's do that by using The TEDs, I use TEDs in upper and lower. Unfortunately, I lost the first photograph with the TED in the lower going forward, but now I'm distalizing upper after mesializing lower, using the same strategy I showed you before with the TED and the loop, and now using the loop for correcting upper class 2 in the right side. Here we have it. How long did it take? Guys, less than 1 year. Less than 1 year to correct that. Why? Using diagnosis after actually 13, but this is after the veneers. 1 year to debond, and then we have the veneers. And because we use the correct diagnosis, treatment planning, and biomechanics. Just that. And we stop now. But for the Q&A, I have to read again. I have a gift for you. Actually, this gift I'm going to give you tomorrow. I'm going to give you some gift tomorrow. I promise you that. I'm just discussing with my team now, but I'm going to give you some things that you can read after the class. I'm going to give you some, okay, I'm not ruin the surprise for tomorrow. I'll tell you everything about it tomorrow. So don't miss it. I need you here tomorrow to the last class to have the gift. I'm not giving you another opportunity, okay? For those who want to know more about my online course, yes, I have an online course. Many people text me asking, yes, I do have the online course on diagnosis and treatment planning. I love this course. Why? Because this course gives me the opportunity to show to you the basics of orthodontics and how to apply that to fasten up your treatments, to give to your patient the right way to treat them. So I have this online course, and I will talk about this tomorrow, and I'll have this offered just for you that's going to be with me tomorrow. And this is something that you're gonna love, I promise you. Be sure to participate in class 3 tomorrow, where we will tackle from theory to execution. I'm going to tell you something about the finalization, okay?